Okay, thank you, and I apologize for not being able to be there in person, but this is something that's very interesting and important, and I'm glad to be a part of the panel. I think that I'm going to discuss a little bit about our experience in designing and implementing a novel machine learning-based scheduling system. And I think echoing what Don said earlier, we're probably going to discuss some low lights leading to highlights and then back to reality. I think that as we go on, there appears to be a theme about this. So back in 2014 and 2015, as many other healthcare institutions did, we participated in the Press-Ganey patient satisfaction survey. And within our cognitive neurology clinic that's designed for people with Alzheimer's disease and related dementia. And as you can see here, on the top blue bars are the actual scores, and on the bottom red bars are the percentile scores. We did very well in terms of time providers spend with each patient, and as well as the likelihood of recommending each provider, including physicians as well as nurse practitioners. But in terms of ease of scheduling appointments, the ease getting clinic on the phone, we were quite a bit below all neurology practices across the country. And when one starts looking at the free text comments, our management team put together this figure on the right in terms of which words and what phrases show up the most. And you can see the big wait time there, both in terms of waiting for an appointment as well as waiting at the appointment. Should be 2014. I'm not sure why it says 2114. As part of the exercise, there was also an evaluation of how many appointment slots were actually filled. And I believe this is my own schedule from September 2014 until February 2015. And you can see that many of the slots were actually listed as available but never booked. And within our clinic, there was a goal of 90% utilization rate in terms of appointment. So it looks like that we really were not utilizing the appointment schedule properly. But there were a number of key assumptions both made in terms of this evaluation as well as recommendations. So assumption number one was that every patient was in the room when the appointment began. And as those of us who see patients know that this rarely happens. And so this is a difference between the next one, between the medical appointment and the legal appointment. And there was the assumption that each medical appointment only lasted up to designated duration. As in 30 minutes up, and we will cut off the appointment. That is difficult to do sometimes, especially when you're delivering bad news. And finally, the assumption was that each appointment was an independent event, that it was not linked to any other processes. And as you saw earlier in the clinical trial presentation, as well as we will see later, that is really the case in a complex multidisciplinary type of clinic. But based on this simple assumption, then you can easily take this to the next level and say, well, there's an easy solution. We don't need to change anything. We just schedule more patients. And this is especially the case when neurology as a department probably generates relatively little revenue compared to some of the other specialties. This is just an example. This is not exactly our revenue, but it's just the relative revenue of different specialties average across, with one being the mean. And so the directive was to schedule more patients. But this was when we started working with a colleague at Georgia Tech, including Eva, who is the chairing the session. And what we found was that a number of the assumptions were not true. And a lot when we discussed with providers and asked them, why were you running behind, even though your appointment schedule was only 40, 50% full? The most common response we got was the patients were late. The patients were late. Of course, during these meetings, patients were not there, so they couldn't defend themselves. So when we look at actual time tracking studies, we found that most of the patients actually arrived on time, as in 15 minutes before the scheduled appointment was to begin. And that was when we asked them to show up. So they certainly arrived on time. So there should be plenty of time for them to get into the room and get ready. At the same time, remember that figure, wait. They spend an enormous amount of time waiting. So on average, about 20 minutes waiting to be roomed. And if you arrive on average 15 minutes ahead of time, you're already behind the scheduled appointment start time. Rooming took another 10 to 15 minutes, and they spend more time waiting for providers in the room, and probably because the providers are running behind from the previously late scheduled appointment starts. And as a result, and going back to the previous presenter's presentation, providers don't like to work overtime too much. And so because of this type of delay at the start, providers start to cut back on the appointment time. Remember that, we still spend quite a bit of time with the patient, but certainly less than the allotted time. And this obviously is a concern both from the patient care perspective as well as the administration's perspective. So this probably was not the ideal solution, despite this being the real world outcome that we were studying. And this is another assumption that was not true. And this is a typical Monday schedule in an academic hospital with 2 clinicians, 2 ancillary staff who will be providing cognitive neuropsychological testing for the patient, as well as laboratory technicians and social workers. And you can see here that this is a highly complex and interlocked system, that if one person shows up or doesn't show up or shows up late, you will actually send the entire schedule into disarray. And that's what happens frequently. So if we're going to come up with a system that automatically improves the scheduling but also time usage, these factors need to take into account. We cannot just look at the ND column in column 1 only. And finally, there's the issue that is becoming very apparent throughout medicine, which is the high burnout rate. In my field, neurology has had the distinct honor of ranking consistently one of the highest burnout rates among all medical fields. This is due to many reasons, but certainly excessive overtime will not improve the burnout rate, and especially given the low both in terms of per patient compensation as well as the per physician compensation. So a question came up, which was, well, can we use some of the pre-visit data to predict case complexity? And so this has 2 goals. One is to avoid burnout. So if you look at my typical schedule of 3 new patients on a Monday afternoon, I can have 3 highly complex cases back to back to back. And I will be exhausted at the end. I will have to cut short somebody's appointment just to make sure that the staff doesn't work overtime. And nobody is happy. And at the same time, there's a potential situation where we'll have 3 really straightforward second opinions. And in that situation, we potentially can spend quite a bit of time waiting for the next patient to arrive if we can finish early. You'll recall that when we look at the time spent with the patients, the physicians can reduce the time appropriately depending on the case complexity. So the ideal goal is to have these balanced schedules on the right side. So you have a high complex case mixed with a low complexity, medium complexity, or a very average situation where you have medium complexity throughout, which rarely happens, but certainly can happen depending on the case mix. And before every patient actually has an appointment, we send them this 25-page written questionnaire to have to answer often just yes or no type of symptoms. And many of the clinics, they have the similar type of process on paper upon arrival, but we just send it out before the appointment is made. So this information can actually be collected and reviewed to see whether we can use machine learning to predict what makes a highly complex case and what makes the complexity lower in other situations. And then so that was what we did in collaboration with Eva's group, and in one of the using one of the models at DAMIT, we're able to predict the complexity with a reasonable accuracy, and I think I was just reasonable to moderate to high accuracy compared to some of the other algorithms. And here the key is to not predict, not to maximize overall accuracy, but to kind of break down the accuracy across the complexity categories, such that even if there is an error rate, which in the real world the physician or the patient will need to make up for, it's easier to make up rather than to have the error rate focused primarily on low complexity cases. So this is the ideal process, and then so currently how a patient makes an appointment is a highly convoluted stage-wise exercise. So they will have to receive this new patient packet in print, and they have to fill it out in writing. They have to mail it back or fax it back. Just imagine the loss of time and loss of materials. Somebody has to review the packet. They have to call the patient to verify that everything is still accurate. The appointment will be made, and somebody may have to guess the complexity based on subjective experience, and then before the physician will see the patient. This whole process can take up to 2 months, and which is really not an efficient pipeline. And so the proposed process, and the one that we, I think, have the bits and pieces ready to implement, the potential patient will contact the call center, and they will be directed to a web page when there's a form that the patient or the family can fill out with the relevant information, not all information, just the predictors that will be useful to predict complexity. The complexity will be determined based on an algorithm that continuously learning according to patient and physician feedback. The patient's schedule the appointment will be fit into the schedule, and then the physician will be able to see the patient. So estimated time in terms of making the appointment can occur within 48 hours. This will represent a significant improvement in efficiency. So the results of the proposed scheduling method in terms of in a simulated change is that we can eliminate days where doctor has multiple highly complex patients that lead to backlog and working overtime, and as well as high burnout. You can eliminate time wasted by doctor waiting for the next patient due to low complexity. You can potentially fit more patients into any one day. If you happen to have 4 low complexity cases, you can see 4 instead of 3 medium complexity cases. And finally, we can actually maximize the clinic's throughput. In our next number of weeks, so we prospectively follow the patients, and then we secured the questionnaire results from 73 patients over the 29 weeks during which they were staying. And if the scheduling algorithm was in place, we could potentially reduce the 29 weeks into 17 weeks just by optimizing the complexity scores alone, and which represented a 31% improvement in efficiency. So this, in theory, would provide a number of benefits to health systems. It could decrease the time-consuming process of categorizing patients, reading and entering historic information, which is sometimes a full-time employee, full-time effort. And it can increase the easy information flow between patients, scheduler, and the physician and clinic administration in terms of the information being entered and the scheduling, the efficiency, and so forth. It can increase the average number of patients seen daily, and which is associated with potential increase in clinical revenue. It can decrease the time between new patient contacts in office for an appointment when an opening is available. At the same time, here's the reality. And we presented this to a number of stakeholders, and similar to the previous presenters, this was felt to be a good idea by some, to be a research-only effort by others. And there were real hurdles, and there were imaginary hurdles, there were theoretical hurdles. And as the previous presenter mentioned, there's also the hurdle of what the priority is at the time. So I have the Lean book in the back, not because Lean is a hurdle for implementing something like this, but because that our healthcare system will begin investment into transitioning to Lean. So again, this had a lower institutional priority. So I think, the themes here are very similar to some of the previous ones in terms of the algorithms and the collaboration between and optimization engineers and computer scientists and physicians can really improve some of these systems. But the system buy-in from the leadership level down is critical for any realistic implementation. So I want to thank you for your attention, and I apologize for the little AV snafu at the beginning, and that I think I'll hand the mic back to Eva.